Welcome, everybody, to New York. On behalf of Dr. Kapoor and myself, we want to give you a warm welcome for this peripheral live case as part of the ongoing MedStream 360 series. It's an honor for us to be here with you to add another case to the archives and also to hopefully enhance your understanding of the treatment of the endovascular treatment of peripheral arterial disease. Again, to my right is my partner, Dr. Vishal Kapoor, who is the Director of Endovascular Services at Mount Sinai Morningside. To his right is our fellow, one of two, and this is Dr. Ibrahim Ali, who's going to be graduating in 2 weeks. So he's excited. Our team here is wonderful. We have Ken Lee, who's our tech, and we have Elizabeth, who's our lead nurse, and we have Freddie outside doing his magic. So we've got everybody here. We got a wonderful case to show you, which happens to do with an iliac, which we have not shown you yet. So without further ado, we're going to go to Ibrahim, and Ibrahim's going to go ahead and present the quick case.
All right, hello everyone. I'm going to quickly go through the case. We have a 49-year-old male originally presented to us with Rutherford 3 claudication. Over the past 6 months, he's been on medical therapy and has failed supervised exercise therapy, and now his pain is pretty much, as soon as he walks less than a block, he has the pain. He has a past medical history of an MI with multiple stents. He has CAD in other arteries as well, and no known RCA CTO. He has heart failure with a reduced ejection fraction, and his EF is 25%, and he actually has a old LV thrombus, has hyperlipidemia and AFib. He's on aspirin, Eliquis, Entresto, Coreg, Imdor, Eldacto, and Lipitor. Obviously not on Pletol because of the heart failure, and obviously not a good surgical candidate because of the heart failure and the MIs. He is a former smoker, which we're glad about.
Give us 8,000.
And initially, he actually came to us for a cardiac cath. We ended up getting right groin access, and obviously weren't able to get to the heart that way. So we got left groin access, did the cardiac cath, and on the way out, we took this picture to kind of understand what was going on. This was treated medically for a long time, and obviously with supervised exercise therapy. And like I mentioned before, now he's starting to fail and presenting to us for intervention. And that's all I have.
Okay, so we've got a person, Vishal, with the CTO of the Iliac. Can you talk about some access points and why we chose what we chose and what the folks at home can try in these kind of cases, what the non-invasive workup should be? Obviously, this is a patient who's followed by our own partners. So let me know what you think, a person at home, how this patient should be followed up.
Right. I mean, it's a very good case to actually view and review with it. I mean, especially patients who present with iliac CTOs. I mean, doing iliac lesions is a different story, but when you're doing iliac CTOs, the thought process of doing them actually changes because you have to ascertain where the CTO is, the origin, the proximal cap, the distal cap. Is it common iliac? Is it external iliac? Is it extending into the femoral arteries? And what's the pathology? So, I mean, most of the times when you do iliac CTOs, we, like PK and everybody would recommend, is getting a good invasive strategy, of course, having a good medical management to begin with, but non-invasive strategies such as doing an arterial ultrasound, but more likely doing CTAs as well to really define the anatomy, the origin of the internal iliac, the external iliac, the flow on the contralateral side as well, which will be an important determinant in treating these patients. So, especially when you're trying to intervene, you want to make sure you do it in a safer environment and you know your endpoints and the success rate. So like in this case, what PK is going to talk about as well is like the patient here has a right common iliac, and you could have multiple options. You could do it endovascularly in this case, which is our preferred treatment, keeping in mind the multiple risk factors. There are other options as well, doing a fem-fem bypasses and other surgical options, which somebody could take if an endovascular treatment changes. But with the evolution of stents, treatment algorithms, devices, wires, catheters, our success rate, especially in our hand, has been exceptionally well. And the chances of treating somebody by an endovascular intervention, meaning with stents and balloons, is much higher. So we definitely want to give it a shot.
Okay, so I mean, I think to summarize, I mean, the first thing you need to do is make sure that the symptoms are from the iliac. So first and foremost, their actual symptoms will usually present with buttocks claudication and/or leg claudication. The non-invasive workup should really involve ultrasounds, for the abdominal aorta and the iliac. And then once you've diagnosed and you want to intervene, if you know this is a plus minus, if you want to do a CTA, you can do a CTA if you're suspecting any aortic disease. The access points, you know, here, can you go next? Play the films. So we got right, left common femoral access, and then we took a picture of our access site next, and you can see he doesn't have any arthritis in his hand, so it's always good. And then now you can see he's doing an aortogram, and you can see that you have a. What's important to look at here is you have to look at your distal aorta, make sure you don't have any distal aortic stenosis. Look at your collateralization. You have a large, I think it's an IMA coming down, a couple of lumbars that are there. And then you have to look at the status of your internal iliacs. So your left internal iliac is occluded, so likely, I mean, you would not want to occlude your right internal iliac in this situation, but, you know, sometimes, you know, you got to decide, you know, what you're going to do, but, you know, as the case goes forward. The other thing is you go to the next shot, please. Then obviously you want to get access on the right side. Next, please. And then you can do an ultrasound or angiography. We chose angiography here. And again, we took a shot here to make sure that we're in the vessel, no dissection at the level of the access side. So obviously the concerning factors here are the length of occlusion and also the fact that the contralateral internal iliac is occluded. And the idea would be is how are we going to deal with this internal iliac. So one of the things that we've learned here is that, you know, a lot of times you have a lot of hibernation in these vessels, and, you know, like we do in the tibial. So it's always good to sort of, you know, decide how you go. And I know I'm going pushing it without a wire here, but I tend to do this just to kind of make sure that I have an occlusion. You can send a wire up. You don't have to send a wire up. And sometimes you're surprised. DSA, please.
DSA is on.
Okay, hold on. DSA, please.
DSA is on.
Yes.
So 1 second, we'll answer all the questions. So you can see here, injection-wise, there seems to be some antegrade flow, which is good. So I'm just going to go up again. I know the internal iliac is medial. I'm just going to go lateral here and inject. Okay, see, now look at this. This is so interesting. You can see that now you can see the level of hibernation. Thanks, bye. So the level of hibernation is very important. So we're going to take another picture here. So you can see here. Okay, so it looks like it's, you know, it's blunt flush occluded, but look what's going on here. Got a little stagnation. So the question is, have I dissected with my catheter? I hope not. That would be interesting. Looks like I have, so this is going to get even more interesting. Give me a wire, guys. So pushing up my catheter, I probably dissected the iliac all the way down, which is interesting because we did not see it in our initial shot, or maybe that's the reason this vessel is closed to begin with. Right, so it could be a dissection that closed. So let's see. So now the best thing to do is when you've now diagnosed this, or potentially diagnosed the mechanism by default, by not knowing, because you don't have a history of a dissection. The guy's had numerous cardiac caths, so that might have been dissected during the cardiac cath. So now we're going to just take a picture from above. Okay, and why I'm doing this is to see whether there's still flow in the internal iliac, right? So there's your flow. So there is flow in the internal iliac. So likely this is a dissection. So now you've made the diagnosis. This is a dissection of the common iliac cath because of the fact, go C minus, that when I went with my catheter and I injected, you can see that there's stagnation of flow ipsilaterally. So the worry now is, am I in a dissection plane from below? So this is going to be much more difficult than we thought because of this situation. So now I'm going to go with this catheter up because I don't want to stent the dissection plane, obviously, which is going to create a major issue. So I'm going to go with my command wire. I chose a command wire to go up, and this is where intravascular ultrasound is going to play a major role for us. So let's go in the command wire.
So you're saying it's a chronic dissection, which
it's a chronic dissection, which is a retrograde dissection, which probably closed at the level of the ostium, and now you're filling through the internal iliac. You see that? That could all be dissection plane.
Wow.
We don't know. See this? See? Now let's take a picture from. I know his EF is low, but we're going to have to really kind of see where we are and figure this out. If that's the internal iliac, then I know I'm in the true lumen. See? So now I'm in the true lumen. So I hope everyone at home can understand what I'm doing here because of the fact that you had the stagnation of flow. I'm going to go ahead and now I'm going to advance my wire because I know I'm in the internal iliac. So now I'm going to go up to here and know I'm in the internal iliac. Now I am in the true lumen, right? So now that I know I'm in the true lumen, Now I'm going to go ahead and come this way. I'm going to have Vishal just help me out by going to that side. And what we're going to do is we're going to now advance the wire. So that's a true lumen. Push my catheter now. And stop. Oh, okay, good. Stop there. Let's see. See? Now is a good time for us to realize that this is a dissection that's been closed at this level. So now we need to take some dye from here. Thank you, sir. Hold this. Now I'm going to confirm, and let's see the flow, how the flow looks.
And the beak.
So we have a little nipple. So I'm going to go ahead and advance, ask Vishal to just push forward slowly as I puff. There you go. And now you can see that the dissection plane is here. Ready? One more time. Okay, there it is. So the question is that a collateral or is that a dissection? So give me a straight glide now.
Straight glide. Stiff? Straight stiff.
Straight stiff, yeah. So you got that, Vishal. So I think that's what we're going to try here. So let's just try to dissect through this and see how we go.
Would you, I mean, I know you've chosen an 035 stiffer wire, but in order to start being less aggressive in these CTO, iliac CTOs, especially, you know, the chance of going subintimal or in a dissection plane is higher. Anybody who's starting, would you recommend starting with lower profile, like in stiffer 014, 018, and then go to 035? I know in your experience, hands, 035 is the way to go, but what would you recommend as a protocol?
I think you have to be very cognizant of not dissecting past the aorta. And I think in these kind of lesions, you know, it looks like a flush occlusion. Obviously, this is obviously a lesion that's going to be quite difficult. So let's see. To me, I think the command wire bounced off. You could start with a confianza if you want,
right,
and try that way. It just depends on how we're going to do it here. So let's see how this wire behaves. See, it seems to go pretty smooth there, right? And so I'm just going to wait to get to that spot. And that's what sometimes you just need to break the cap and then need to decide. And I usually not in a very big rush. I try to figure out where I am in two different views, right? And I try to look at how the contralateral iliac comes as compared to how the ipsilateral iliac goes. Liz, any questions we can answer for everybody?
There's so many.
Uh-huh.
But most of them, you're asking me speaking. So the last one is antegrade wire dissection reentry. First strategy if proximal path cannot be penetrated.
Well, yeah, I think it's a little early to talk about antegrade dissection entry. We're doing retrograde here at this stage, but we first need to try to get to where we're going. So you see here, it looks like it's moving in this direction.
Right.
So we're going to try to just, now I'm going to tell you to advance your catheter. We know we're not in a collateral here, so let's just advance the catheter. Any resistance?
No.
Okay.
Very nice and smooth. That's why I'm going slow.
Good. Okay, let's stop there for a second.
Yeah, I think that's an important point. Here it's more common. We have a little bit of pushability from down below. If it was blunt or a little bit of knob, you might start thinking about going antegrade, but like PK rightly said,
I think we crossed.
We crossed.
A good deal, sir?
Beautiful. Yep.
So you see, we've now crossed. The question is, how did we cross? That's the only worry. It looks like we're a little ipsilateral. Go forward in. Okay. Okay.
Yep.
Okay. Okay. So now let's not. Okay, give another.
Now we cross. So yeah, we give it 3. Yeah.
So now we'll just check our position.
Nice.
So we know now we're in. So now we need to go ahead and get a stiff wire up, like a supercore. Actually, before that, we should do an IVUS, right?
Yeah.
So give us a Sparta core.
Yeah.
So let's do an IVUS, and then we decide.
Okay.
Yep. No, you hold it there.
Okay,
I don't want you to lose
exactly.
the catheter.
Yeah. Right.
Thanks, brother. Yeah, what's going on? So, yeah, for those at home, the antegrade cross is only something that we're going to do if we don't do it. What is that? Silver or supera? Yeah, that makes sense.
Okay, would you have used, like, let's say thinking about antegrade axis, would you have used just the left radial diagnostic like a French catheter and put a pick down the left radial visualization?
I think it's 100%. I think it's an absolutely smart idea. You know that very well too, Vishal, that if we need to do it, we're more than ready to do that. We just felt looking at this that this should be something that's, a bailout if we're not able to cross and then take it from there. So what we're going to do now is, now that we're done, we're going to do a quick IVUS. So there's a lot of talk here about, R2P. I think R2P is a fantastic way of doing this. I think R2P is something that you can absolutely do. The only problem with the R2P is in these kind of cases, if you get into any sort of issue with perforation, dissection, or anything like that, you're really going to run into the trouble of having to deal with any sort of bailout devices coming from your radial. So I think while R2P is a great idea,
I have the wire,
and I think it's definitely part of the future of our peripheral arterial disease, like it has become so much coronary disease. I think that clearly in this situation,
can you increase the gain?
Increase the gain a little bit. In this situation, it may not be the right thing to do. So I think we could have used it to cross, and you can see the catheter in our field here. So we're just going to pull back.
Start recording, please.
Start recording. You can see IVUS in the aorta. You can see the catheter moving with the IVUS. And then you can see as we come down, you can see we're in the vessel and the aorta all the way. And then right about there looks like the CTO.
Right there.
Okay. And are we subintimal? Can you increase the gain, guys? There you go. Okay. Yeah. It looks like we're in the lumen, huh?
Yeah. It looks
like we're lumen.
Right dot in the center.
Right strut through the lumen. Maybe right there, a little subintimal. And then we're a lot of debris in the lumen.
Yeah.
And then we came out. Now we're in the true lumen.
Okay.
Come down. Let's see whether we see a dissection. See, so it's a retrograde dissection that really probably started with the flap is actually tacked up by the occlusion. So we got to make this assumption that this is an issue.
Okay, stop.
So now can you do the measurement of the external iliac, please? Yep. So at this stage, now that we're done with the IVUS, now we're getting some measurements and then we're going to decide. So give us a 5040 balloon, please.
035.
Actually, just work on this wire.
Yeah,
sure. Because you know why? Because the VBX, everything is going to go through. Oh no, the other one's going to go through an 035, right? Yeah. The live stream. Yeah. So let's use this. Let's change out. So what we're discussing here is what wire to change to. 035, please. So what we're doing is we decided to change out for an 035 wire because of our thoughts of what is a definitive therapy going to be. And I think here a couple of the things that you got to think about as an operator is, what's exactly happening. One is if you do perforate, what's your bailout going to be, and then how you're going to be able to do that with what type of support. So as most of us now, we're all doing a lot of 014, 018 systems. I think in these kind of situations, most of our large aortic occlusion balloons, as well as our large iliac stents, are going to go through 035 wires, and they're actually, for lack of a better word, they're basically trucks. So in order to be able to get it in and get it across these lesions, make sure you fix the sheet. Yeah. Get it across these lesions, you're not going to be able to track it if you don't have a good, strong wire system. So in this situation, I think it's smart to switch out for an 035 wire, and then we're going to go ahead and take a system. Liz, how much heparin did you give? So, and what is the second time you gave?
I'm ready for these.
Yeah, I'll give it right now.
So we're going with an undersized balloon here. We're going with a 5mm balloon. I know a lot of you may be thinking, why is he using a 5mm balloon? We're using a 5mm balloon just to make a channel and just to kind of understand how we enter the aorta and how exactly are we going to go ahead and treat this aorta based on what we see. Yep. So Dr. Kapoor has just pushed it all the way up. We know that he's probably across it now, but that's okay. And we're in an AP view, so we're just going to take a little 2 cc injection here. Yeah. Just 2 cc to make sure we're in the aorta. Okay, that's fine. Let's go up here. Okay, good. Just a 5mm balloon just to get a channel. 810. Okay, down.
You're doing
I know
all right.
It's super small, and I understand that you may not even get flow, but I'm a little conservative in these type of occluded aortas. Oh. Okay, down. And it's definitely undersized. I just want to balloon across the internal just to make sure we're getting flow. And then we're going to decide. Okay. Ready? Just enough to see. So there's our vessel.
Nice.
So now you know you've got a vessel. And also I'm also looking at the contralateral iliac. So what I want you to understand is in a lot of these cases, Vishal, as you know, there's unraveling of the aorta.
Yep.
So even though it looks like you're on one on top of the other, you're really not. So therefore, what we're going to do is we're going to go ahead and continue to treat this as this. So our IVUS measurements, can you go back to the IVUS, please? And please notice the gradients still haven't changed. You can see the two gradients there. They have not changed.
Point. That's a very good point, yeah.
So when you see the IVUS, this is the external iliac right at the proximal.
Yeah.
So you can see it's about an 8 millimeter external iliac. So you definitely want to be able to go one-to-one with that. So now I'm going to be aggressive. I know I'm in a good luminal situation here. And I'm going to, since it's unraveled, I'm just going to go lateral a little bit. Maybe I'll go this lateral here to see. This is probably, maybe the other one's better.
Maybe the other one, yeah.
Yep, this is probably better.
Right there.
So I'm just going to go ahead and take one last, just a shot, just to see the ostium a little bit to understand. Yeah. All right, give us an 8 millimeter, 8x60 balloon, please. So we're going to expand to the 8x60 balloon. Any questions, Liz? Yeah. Well, that's why I think there's, so the question is, are we surprised there's not much calcium? Vishal, do you want to take that as a comment?
Well, I mean, like PK talked about, it's all about the mechanism of action of the iliac disease. I know he has a lot of premature coronary artery disease, multiple stents, low EF. So we were expecting more PAD in this case because we know CAD is a risk factor for PAD. But like PK was talking about, the mechanism here is not really calcification, but more of a traumatic injury to the vessel, thereby leading to the shutdown. If you can see, the rest of the left common iliac is pristine, pretty much pristine unless we do an IVUS. It looks very nice, big size, and so is the access site. So I think PK's word of knowing that what the mechanism that led to the occlusion is, I guess, the most important determinant in this case. And also you could see from the ultrasound there is not much calcium, again suggestive of less of an atherosclerotic disease, even though there is some plaque, but more of a healing process of a chronic dissection plane.
Okay.
Yeah, of course, I'm sure PK will agree that if there was calcium, he would have probably opted for shockwave as one of his initial, I'll pull back a little bit, initial strategy to prep the lesion before he goes for his definitive therapy.
So we're going to go up with an 8.0 really slow, watching how the balloon expands and how the patient reacts. What's nominal, guys? Slow.
I'm at 2.
You okay?
You gave 40 Lasix?
Yeah.
6. Nominal is 8. 6 is fine.
That's good.
I'm at 4.
Okay. We'll go to 6.
6.
Almost there. Yeah. That's normal.
Okay. As you know, you need good nursing and good communication with the patient. So now, you also want to look at the balloon expansion. You want to go in the AP view, see how the balloon is. So it's not really central luminal, but it's not eccentric. If you notice the wire on one side of the balloon or not, then you know that you could be very subintimal in the AP view. So here you can see in the AP view, it's central-ish. So I'm okay. Are we across the internal here? I think we are, right?
We are, I think.
Okay, down. So in this situation, after we inject, when it comes back, you want to look at the pressure, and then you want to see what happens with the pressure. So clearly the pressure is starting to come up, but not really.
So it's better waveform.
So it's definitely a better waveform, and it definitely seems to come up. And also the pressure hasn't dropped. That's probably the more important thing. So now I'm going to just walk this back here, and then you can see the pressure is still kind of lower compared to the main one, but it's 150 when it was 110. So you can see now that's a much better picture of where we are. So now I've got a nice thing. So now I'm gonna go ahead and decide on my stent.
0 both, please.
I'd probably put a dilator and advance that up a little bit.
Yeah.
So we're going to advance this up a little bit with the dilator.
We're right at the 0 both.
Okay, give another 2,000, please. 1,000's enough. So we're 0, but we're still not equal here.
Yeah.
So we're just going to put a dilator up and just push this up to the internal iliac, external iliac junction here. There we go.
Right
A
there.
little more maybe. That's good right there, yeah. So now we're going to go ahead and walk this out just to have better access at this level. Yep, so we still have not cleared the gradient, which is kind of interesting. So I think in this situation, we need to understand why the gradient is not cleared, because we went up with an 8 millimeter balloon. So let's go, we went up with an 8 or a 9? 8, right?
8.
So let's, interesting. So the issue here is, do we re-IVUS to see zero
Zero
bolt,
one more
please?
time,
Zero
please.
bolt, please. Yeah, this is another good thing that Dr. Kapoor is doing, is to zeroing both to make sure that everything looks really, really good, and then deciding why. So that we did zeroing of both. Okay, now I usually wait till both go 0, 0, 0, 0, 0, and then I think that now you're truly zeroed. Now we open both. So it's a little better. Let's flush everything, flush our system here. So flush the other catheter. So we're flushing our systems. And then let's see. So the other trick you can do is try to switch transducers.
Yep.
So let's switch transducers here. Hold on.
Yeah, I'm going to just
take this out. Put that on that. I'll put this on this. Another way to see whether you are flush both, please. Flush.
Flush.
So sometimes, as good as everything else, you want to make sure that everything you're smart with everything. So now when we switch everything, see? So it's a problem with the transducers. You see that? So for those at home, anything can happen. Now I switched transducers, and now you can see that the same pressure gradient is in both. So actually our iliac pressure gradient is now 174, and our aorta has dropped to whatever it is, which we're not even able to see. So I think this is a good trick. I mean, this is something I think it's not nobody's fault. I think hemodynamics are very important in the iliac, because otherwise you're going to repeat balloon this, saying I've not expanded the lesion. Right. And then what's going to happen is you're going to create a problem. You may perforate. So we had the IVUS there telling us the anatomic gradient. Now, physiologically, you don't really have a gradient. Why am I not getting an aortic pressure? Why is the red not reading? Zero again. Well, zero again. So I hate to sound redundant, but I think this is very, very important for everyone to do this. Okay. It's not 81 though. See, now you say you have the reverse gradient. It's the same. So that means you've reduced your gradient in your iliac to 0, in your common femoral to 0, because the blue is now the common femoral gradient, common femoral pressure. So it's 169. Now and the aorta is now say 50. 93. So we know the aortic pressure is not 53 because his cuff pressure is 161. Okay, so that's a very important learning point for everybody at home. So now we know we're not going to do anything, right? You okay with that?
Yeah.
Was I mistaken or was I not mistaken?
Yeah, you were mistaken.
Oh, I was mistaken. So let's re-switch again.
Yeah.
No, was I? Okay, let's do it again. Let's one more time. I guess I goofed because I'm thinking one thing versus the other.
No.
So we're going to now re-switch. Because this is very important. This can happen.
No, that's the switch is now going to happen.
Okay, now we're going to switch. Yeah. Okay.
Yeah.
So
let's switch to
again.
Our original.
Wait.
Manifold on CFA and the.
No, but that okay.
Okay,
let's do it again.
Yeah.
This is very important, guys, because I'm telling you, I think we expanded this. I'm surprised why our.
Hold on. Let me aspirate and flush this.
No, I'm not mistaken, Michelle. You'll see.
Flush forward, Abraham. Flush, please.
Okay, good. Okay. Okay. Let's zero both now. Okay. Let's go to pressure. Okay. Let's now turn the common femoral off.
Turn the common femoral off.
Mm-hmm.
Okay, here.
Mm-hmm. So the aorta is now what?
171.
171.
No, you don't turn it off.
No. We're
Just
gonna-
keep the bar on.
We're doing it here.
You're doing it here. Yeah, please.
Okay,
Thank
so
you.
now the common the aorta is 170.
Yeah.
Now, do me a favor, turn off the common femoral.
It is off.
Okay. Now turn on the common femoral. Okay, and what we're going to do is we're going to detach the common femoral.
Correct.
I'm going to put it on the aorta.
On the aorta, right.
Ready? Let's see what happens. See?
No,
So the aorta and the common femoral are exact.
No.
No.
Now this is the common femoral. So this is back to
No.
171. Yeah.
That's blue.
This is
You
the
said
aorta.
the manifold was a common femoral before,
Correct.
right? And the aortic pressure was 170.
Which is again on 170.
Right. Oh, I see what you're saying. Oh, so we should do it the other way. Let's do it this way. Flush forward, guys. Okay, do it again. Let's see. Yeah, I see what you're saying. So that's not improved.
Correct.
All right. So I guess we have to reballoon that. Let's get an IVUS. Let's see the IVUS. Flush forward. Let's get an IVUS, guys.
IVUS is right here.
Let's get us another IVUS. Now we need to see whether there's any recoil or not. So my theory of the pressure gradient was totally wrong.
The other thing is, I mean,
What else do you think it could be?
if it's a dissection flap causing this, as soon as you balloon, the flap goes back.
Goes back,
the
yeah.
gradient
That's a
goes
very
That's
good
what you
point.
said. The
Stent it up,
recoil is what.
and
Well, no, we have one.
No, we have it. Yeah, that's what,
We're just
like you
gonna
said,
change out.
I think it's the recoil.
So now
of
we're
it.
going to do is go ahead and see whether Dr. Ibrahim's idea that the dissection flap flip back down could be it. Yep, perfect. All right,
Yeah.
give us the Spartacore again. So we're going to try to make sure that the IVUS flap does not flip in. Because if that's happening, then his stent is going to work. TEE?
DEB, drug-eluting balloon.
Drug-eluting, there's a question on drug-coated balloons. Drug-coated balloons are not indicated in the iliacs because they have not been studied. They've been studied in dialysis grafts. They've been studied in obviously lower extremity in the infrainguinal segment. They've been studied in the coronaries outside the U.S. Currently, I believe they're in trials in the U.S. in the coronaries. However, they have not been studied in the iliacs.
Yeah.
Main reason for that is the iliacs are a region, obviously, with the patency rates are phenomenal. So Vishal, can you talk a little bit about, let's take a look at the IVUS and then decide with each other, why do you think this happened?
Yeah, I think that's a very good point. But for me personally, I mean, I understand even if it's a recoil, I would probably be, I don't know, personally, I would probably be a little bit, I did an expansion with an A balloon, like you said. The balloon expanded well. There were no areas of narrowing or compression. So that's a good sign that at least the lesion did open up technically by balloon.
Okay, we're
so
across.
the only thing is, are we missing, or did we really truly miss the ostium?
Good point.
See how the IVUS just jumped through?
Okay.
Maybe we didn't
Record,
really go to the
please.
true ostium. And maybe that's
Record,
why.
get us an 8.0 balloon, please, another one.
another one, the same one, no?
No, the deflated balloon is better to use. It's probably not good to use.
See that right there?
Right there. So we might not have hit the ostium.
And now we see the lumen open
So
up.
we have to go by the iliac. Okay, that's a great point. So, and IVUS again shows the ostium
Opened up so
has
well,
not been expanded.
All right, stop recording.
So now we're going to go with the 8.0 long 8.0 balloon, 8.0 60 or 80. Yep, 60 is fine. So now we're going to advance. Show me the last balloon inflation to see how far up we were. Okay, I guess that was it. So we have to go a little bit across it. Maybe go
After
past
that one
the
mark,
line. Yeah. So this is a great example of, again, hemodynamics, first of all, being accurate and not inaccurate like I was thinking.
You're fine with
That's
the
fine. We'll switch it out when it gets up there.
Fine.
And now we're going to go ahead and now expand this and then decide whether the gradient improves. If we get it, now we also identify where the ostium is. So now we know where our ostium is, and we have to know where to put the stent so we don't miss the ostium as well, especially in this unraveled aorta. Wires to you. Okay. Pull it to him. So now we're going to go up with this past the centimeter mark. Push this up a little.
Yeah. Oh, right there.
Let's go up. Right, we've
He's on
given the
Eliquis
patient
already.
Plavix.
He's on the
Anticoagulant.
Eliquis for AFib.
And we're just using heparin as well.
What is your ACT
ACT is above 250.
Right there. Yeah, I think what we usually do is we start on a lower ACT like 200, especially CTOs, iliac, we cross, and then we recommend to going up full. You could do a full on begin with, but just to be honest, yeah.
My AP was, you're fine.
Yeah.
Let's go to 6 atmospheres like you were. Okay. Very good. Down. Now let's hopefully the pressure will pop up to maybe our theory is correct. Give us an 035 wire here.
Let me go up with the balloon. No.
Now I'm going to switch out my wire and go with an 035 wire here in case I have any issues. Still the gradient is quite high. So now it's maybe a recoil issue that we're dealing with.
Yeah.
Walk it back. I think in this case, it would not be a first strategy. It would be a second strategy for antigrade. Come from the radial. We have a injector.
You have a syringe, Liz?
So you can see the pressures are much improved now.
Yeah.
Waveform better, but still not perfect. Oh,
saline.
We're injecting through we switched.
Yeah, we switched.
Yep.
You're right. Yeah.
You can inject from above, yeah. Ready?
Yeah.
Hope you fill it.
Yeah.
Okay. Did we lose the internal? I can't tell. Nope.
No, it's coming right there.
All right. So now since our gradients are better, I want to see where the aorta comes back. Switch the transducers.
Yes.
So we decide now to go with our stent, and now the question is balloon expandable, self-expanding, or covered. What do you think, Vishal?
Well, for me, specifically, if it's an iliac CTO, covered stent is the way to go, like you talked about. Even though we did IVUS and we claim that we were intraluminal, but still keeping in mind the CTO, and you might have entered subintimal in places. I am a big proponent of using covered stent, especially in iliac. I mean,
in this case with your CTO, with your internal iliac,
yeah,
I mean, you still use it. You'd cover your stent across it, or you'd leave that alone and not worry about it. But the CTO started at the level of the internal.
Right. I mean, you're absolutely right. I mean, there's some lumbar coming proximally and the internal iliac, and like you said, there's nothing on the left. But I think we still, if we try to do it, there is still a little bit of small area where if we could land it more proximally, and then probably put a short, self-expanding, not covered stent distally if you're really concerned about keeping the internal iliac open.
Well, I mean, I know the data you're talking about is the COBAS trial, but then there's other data that's come out since that have shown no difference between covered stenting and self-expanding or balloon expandable stents at this area. So that's my only question. My only thing is, in this situation with the internal iliac with really no subintimal, minimal subintimal cross, should we just go with a regular iliac stent is my question. Let me take a look here. I mean, that's the only question. I think in this case, you can, you could probably do a hybrid, maybe a self-expanding and a balloon expandable, but if anywhere you're subintimal or dissected, it's probably going to be at the level of the aorta. Correct. That's my only worry, but at the same time, it's going to be pretty hard to land this right at the ostium, and it's very hard to tell where the ostium really is.
So we could probably do a covered stent proximal 2/3, and where you see the vessel plump up, because we know hopefully the chances.
Well, we can IVUS.
We have the IVUS again, exactly, and then
the difference is that you're going to go ahead and use two stents, two covered stents. Then, all right, give us an 8040. We have an 8026, right? Self-expanding. I mean, stent. What other size stents do we have? Covered stents, live stream.
8029.
8026, 8016, 8026, and
you have anything longer than 8026?
37.
You have 37? Give me an 8037 live stream then. Oh, beautiful. Beautiful. Very nice. And that goes through a 6-7 French sheet?
Yep.
Yes.
Perfect. Oh, beautiful. Absolutely gorgeous. So we know that we're gonna land short of the internal on this because okay. Give 1,000.
Is intricate.
Mm-hmm. So now we're gonna go up. And we know there are multiple coverage stents. We can use VBX here. You can use live stream here. We've decided to use the live stream in this particular case. So we're going to go up now. They're both all indicated for the same reasons. And now we're going to go up. And then we're going to take a look. So there's the live stream stent going up. And is that where we thought the ostium was? Go to the balloon expansion. Go to the balloon. We didn't take a picture of the balloon.
No, then we saved it.
We saved it. We'll go to the checkered box.
That's the first one, right?
Yeah. Because we went LO.
No, did not save it, unfortunately. So now we're going to have to try to figure out where the ostium is again. Is it 0, 0?
It's 3. Yeah, remember we did LAO 3 and...
Let's see here. Ready?
Way high.
We're going to come back slightly.
Yeah.
So we're going to come back just slightly. I think that should be good. Ready? Let me go to one more view here. Let's give a little more Lasix. Okay, my friend. A little more. Give
we already
more.
know the stent is behind the black dot, so that's another important thing to notice.
I think that's good.
Yeah.
I think that's good. Let's go up here. You okay with this, Vishal?
Yeah, I think so.
I am. Go up. What's nominal? 8. Okay. Uh-huh. 8. Okay. Mm-hmm. Okay. Let me go AP and save it too.
Mm-hmm.
Don't come down yet. Uh-huh. Okay. Down. And you have to impringe into the aorta because you're trying to hit the ostium. This is a flush occlusion. So as this comes down, we will then see how this one looks here. And the pressure is still not improving for us. There you go. So pressure is getting pretty much close to normal.
Yep.
So it looks like we definitely hit the ostium here. And you can see by the waveforms, it's almost equal 1-to-1. So in this situation, I'm just going to go forward a little bit and just go a little bit higher, go up a little bit. Just go to 10 here just to get the ostium. Nope, forward.
Uh-huh.
Uh-huh. 6, 8, and 10. Okay, down. Okay, good.
Nice.
So now we know we got it. So now I'm just going to let it come down. Okay, 1 second. Is it down? It's down.
Mm-hmm.
Make sure I don't move the stent. Okay, let's take a DSA here. Very nice.
Wow. The lumbar is open.
Yeah, but now the question is, what are we doing with
our
bottom? So I think we should re-IVUS this and look at it. So let's push this back in and change out the wire. So we're going to go back in again and change out our wire and re-IVUS this to understand how we are in the ostium. Okay, good. I'm going to re-IVUS. And then we're going to decide what to do here. Oh, sorry.
No, the wire is going to fall from there. Okay.
Mm-hmm. Mm-hmm. Mm-hmm.
Yeah, I think the use of IVUS in this case is definitely warranted. You can actually see your PKL absolute right. The pressure difference is now barely 3, which is technically negligible, 0. So
yeah, I think you needed to get us a new Spartacore, guys. This one's kinked. New Spartacore wire, please. This one got kinked on us. So we're going to go ahead and now do a re-IVUS, and we'll be taking it away here. So
I'm right here.
You're good. You're good, my friend.
Mm-hmm.
walking out. Walking it out, guys.
Mm-hmm.
Okay, now we're going to take this out, and the reason we're doing this IVUS now is really to understand how this vessel works distal to the stent. So, I mean, we know our gradient tells us physiologically we've achieved what we wanted, whether the mechanism was recoil or something else. But I think the mechanism was a combination of recoil and also the combination that the ostium wasn't properly dilated. But even though we dilated the same area we hit the stent, we still know that the pressure gradient was not completely relieved till the IVUS showed us. So, no, okay, we're going to come from
Yeah,
above
well, let's
down.
see
Yep,
the stent as well.
Okay, we're going to record now. So aorta coming back right into the stent. Beautiful. Stent is well expanded. No indulations. Just going to step on floor for a second. This is coming to the distal edge of the stent. We have to stent this.
Yeah.
You can see the plaque there, and then goes. So, okay, we have a short segment of severe dissection, and then down in. So the external iliac was 8, right?
Stop recording.
So give us a 9030. Oh, 9040. Might as well go across the internal.
Yeah.
You don't want. I don't think we're gonna have a problem. Let's go to get a 9030 or 9040, but 9030. 9030 absolute pro.
Yeah.
So now we're gonna it's right here. We're gonna put a 9030 self-expanding stent in the iliac. Gradient's already gone. Show us the hemodynamics again, please. And we'll be done in a second. You have a 9030 or no? Yep, perfect. You don't have a 30? Okay, give us a 40. It's not going to hurt us.
Right.
Okay, 9040 we have, so that's fine, 10 millimeters. So in this case, the internal iliac ostium doesn't have any lesion, so I don't want you to worry about that you're going to close the internal iliac. Any questions, Liz? Close the internal iliac. So we're just going to go ahead and take a shot here, and we'll be done with it.
Okay.
Good.
Perfect. Yeah, I think you're right. The open cell design of this stent will definitely help keep the internal open, especially it's a big vessel. So.
Sorry.
He's got to pee, guys.
You can pee. That's fine.
We're gonna give it to you now.
No.
No, we're gonna give you the
wire here.
Okay, let her do that, please.
Okay, go.
Go ahead, Liz. So, since there are no questions for the audience, I think that what we're going to do is
relax.
conclude the case as soon as we put
wait a second
the self-expanding stent in, and then we're going to go ahead and conclude this case. I think we've really shown you sort of the idea of how to cross some of the hemodynamic considerations that you should consider, even though my theories were wrong. I think that that's something that you should always look at, is whether you have a transducer issue or not, and then take it from there. Because because I was getting confused on the transducers, but clearly, if your aorta was now dropped to 30 millimeters, then that's an issue. So now you know the aorta was not, and you know that was normal.
Go, you can pee.
But clearly, the mechanism was also shown by the IVUS, which I think really saved the day in this particular case by letting us see what we're doing here.
Ready? The wire fix.
And now we're going forward. And then go into it a little more. Good. I'm going to take a shot from above.
Hold on, let me get my sheet.
That's fine.
Okay. Let me pull back a little bit. We're way in.
Where does the stent start here?
Right there. At 4, actually at 5.
Oh yeah, now I see it. My eyes are so bad. I think it's
No,
pretty
no.
good.
We like the distal end because distal
You
end
want to
might
come back
flatter.
a little
Yeah,
bit
yeah, I
more?
want to pull
Okay.
back because there's a good
You have
overlap.
Slightly,
yeah.
but I think you're good. Yeah.
I would probably
Okay.
start from here.
Go ahead, deploy it, Ibrahim.
Ibrahim,
So
go.
Ibrahim's going to deploy our stent here. So we're just going to cover the disc ledge because we did all
Slow,
this
slow,
hard
slow,
work.
slow,
It
jumps.
always tends to jump forward. So he's going to pull it back and he's just going to deploy
Slow,
it.
1.
He's going to let it flower.
Yeah.
Yep, he's going to let it flower.
Okay,
Good.
good. Uh-huh.
Okay, great.
Nice.
So we're going to post balloon this with a 6.0 balloon. Give us a 6.0 balloon, guys.
I have the 6.0
Yep.
from before.
We have one from before, which you didn't use.
No, we used it.
Yeah, give us a new 6.0 60 balloon. So there it is. Beautiful stent. Internal iliac is open. Everything is open. So for those of you at home, you can see the gradient is normal. Iliac is crossed. We're going to do a 6.0 balloon, and then we're going to take a final pictures, and we're all done. So thanks again for joining us here in New York for this wonderful MedStream case. Thank you to Vishal and Ibrahim for helping us with this case. And we'll see you, I guess, next time. So thank you again.
Thank you.
Take care, guys. Bye-bye.